So then I started shadowing a periodontist, and I really, really fell in love with the surgical aspect and how clean it was. It was very organized, controlled. It made sense. There was rationale. There was literature. So I just fell in love with perio. So I decided to jump in and go for it. And then now here I am in sunny San Diego.
Welcome to the Newbie Dentist Podcast. I'm your host, Dr. Omid Azami. I am excited to be bringing you a new series called Newbie and Friends. And this is episode 1 of the Newbie and Friends series, where I hope to catch up with past guests and friends of mine to reintegrate into general dentistry. I've been away from general dentistry for about a year and a half now, working full-time in a hospital setting in the oral surgery department, where I've been lucky enough to get a lot of exposure to oral surgery, taking teeth out, surgical extractions, and managing medically compromised patients, which has been a great sort of career-altering or career-shifting experience. But on the downside is I've been away from general dentistry for a while now, and I feel like I've sort of lost a lot of my skill and knowledge. So what I'm hoping to do over these next few episodes is to catch up with a broad spectrum of different clinicians to try and pick their brains, to try and reintegrate back into general dentistry. So to do so, I thought I would start with the foundation, which is perio. And I believe this is my first periodontist that I've had on the Newbie Dentist podcast. So I was really excited to chat with Dr. Yvette Carrillo at Perio Princess on Instagram. Dr. Yvette Carrillo is a periodontist out of San Diego, California, and she graduated from Loma Linda Dental School back in 2015 and is one of those gunners who managed to get into perio straight away, finishing up her perio training back in 2018. She is currently practicing in San Diego in private practice and also does part-time clinical floor teaching at the grad perio faculty at Loma Linda. In this episode, we do sort of a Perio 101, looking at diagnosis, clinical exam of patients, and have a chat about surgical and non-surgical management of perio, as well as some basic introductions into grafting and managing of recession and exposed root surfaces, some of the common perio things that dentists would see on a day-to-day basis. I hope you guys really enjoy this episode and take away from it as much as I did, as I think it is always a nice refresher to speak to specialists, especially young specialists who are up to date with the latest and greatest, and to be able to get their insight into what their specialty entails. This week's episode of the Newbie and Friends series is brought to you by my good friends at Mordent. Mordent is your proudly Australian-owned and operated partner, driving the charge forward in integrated digital dentistry. Being the only fully integrated local dental company, Mordent offers world-class education, equipment, products, solution, and support. The Mordent team of over 50 local solution specialists are helping thousands of Australian practices to seize the opportunity in digital dentistry, transforming treatment for dentists and their patients alike. Whether you're seeking to upskill through education, or considering implementation of digital workflows in your practice, or just looking for some advice, I highly recommend reaching out to the Mordent team. Visit www.mordent.com.au, that's MOREDENT.com.au to find out more. As always, if you're new to the Newbie Dentist podcast, thank you for checking us out. Be sure to head back and check out the previous episodes that I've done on the podcast. I've had the privilege of having some amazing guests on the podcast over the past couple of years. If you're returning, thank you for your ongoing support of the Newbie Dentist podcast. I hope this mini implant audio residency is full of value for you. And if you are getting value, please head over to iTunes and give the show a 5-star rating. These ratings help the show get more traction within the dental community. Without further delay, enjoy this week's episode. So I'm joined today by Dr. Yvette Carrillo, who is a periodontist out of San Diego, California. I think, and I haven't gone through a double check, but I think you're the first periodontist to come on the podcast. So I'm very excited to talk to you and to go through, overview of perio, a bit of a perio 101 sort of episode. A bit of background and context on this sort of new series that I'm doing, the Newbie and Friends. I've been away from, general dentistry for a little bit, and I just feel like I've forgotten everything. So over the next few episodes, I'm hoping to talk to a lot of experts, some restorative dentistry, some perio, some endo. So I'm really sort of excited to get to pick your brain and pick your expertise a little bit over this next sort of hour, and try and learn as much as I can personally on a selfish level, and then hopefully pass that on to the listeners as well. So if you don't mind, normally how I start these off is a bit of an origin story. So just tell us a little bit about yourself, sort of why you got into perio, and then we'll kind of take it from there.
Okay. Well, thank you for having me. First of all, I really appreciate it. I'm excited, a little bit nervous to be the first periodontist on here, but definitely excited. So a little bit about my backstory. I grew up in rural New Mexico. It's like geographically close to Texas, close to the Mexico border, south of the US. My parents were both born in Mexico, and then they immigrated to the US, and then went to college. I kind of always knew I was going to be a dentist. I just didn't think I was going to stay longer and specialize. Here in the States, we do 4 years of our bachelor's, most people, and then 4 years of dental school, and then perio was another 3 years. So it seems daunting. I didn't think I was going to specialize. I didn't know there were specialists. My dad's a general dentist, but he's like what we call a quote unquote super GP. So I just assumed everybody practiced how he practices, and everybody does implants, and everybody does ortho, and everybody does all these like full mouth rehab cases, which is not really the case.
Yeah.
So I didn't think I was going to, keep going. But as I started learning, and I started learning about perio and the systemic links, it just made sense. It was really easy. And so then I started shadowing a periodontist, and I really, really fell in love with the surgical aspect and how clean it was. It was very organized, controlled. It made sense. There was rationale. There was literature. So I just fell in love with perio. So I decided to jump in and go for it. And then now here I am in sunny San Diego.
Yeah. So tell me a little bit about the process, because I know sort of in Canada and the US, a lot of people seem to go straight from dental school into specializing without having had to work for a little bit. Whereas here in Australia, it's sort of it's not like a written rule, I don't think, but it's more sort of understood that you're going to have to work for a couple of years as a general dentist first to get some clinical experience before you can go into any sort of specialty. So what was that process like for you? And do you think, there would be some benefit of having worked a little bit just to see what you like and don't like and before you commit? Or are you happy that you can kind of get through it as fast as possible and start working?
Yeah. In the moment, I just wanted to go through it as fast as possible and get it done and start working, because I saw my friends were working and, moving on with their lives. And I was like still here in school. But now on the other side, so I'm faculty too at Loma Linda. So I did my dental school there. I did my perio there. And then I'm an adjunct faculty there. So it's interesting to see the other side, the students that go straight through like I did. I actually wanted to do like an AGD or a general residency first and then do perio. I was late in the application cycle. I was still kind of like self-doubting myself. And I thought, I'm not going to get in. There's all these smart people. I'm not one of those people. And so I thought I'll strengthen my application if I do a general residency. I can learn more restorative. So I was going to do that in Northern California, and then someone dropped out. And so that's why I went straight through, because I got that spot, that empty spot essentially, which was amazing.
Well.
Yeah, for me. I actually bumped into that person too at the airport one time, which was really, really cool in the Phoenix airport. Yeah. So I thanked her. But so now as a faculty and being with the students and the ones that went straight through from dental school to residency versus it's kind of half and half. The other students, they were either dentists in, foreign countries and then did the international program, and then now they're back in perio, or some were out in private practice for years and went straight through. There's a difference in the way they treatment plan, the way they speak to patients, their chairside manner, their surgical skills. So it's this huge gap, which for me now as a faculty is really tough. So I do think there's a benefit. I know it feels like I was that person. You feel like you're in a rush. You feel like, I want to pay off my loans. I want to do this, but there's a benefit to doing a little bit of private practice at least.
Yeah, it doesn't hurt. I think there's no sort of right or wrong. I guess everyone has their own path and journey, and they kind of get through it. And so tell me a little bit about sort of your current practice. I know you do some teaching and you're working sort of in San Diego as well. What's your sort of normal clinical week like? What kind of procedures and stuff are you doing mostly, or what do you enjoy doing the most?
Well, I love soft tissue. Of course, implants, bread and butter for perio, osteosurgery, that kind of stuff. But I love gum grafts, soft tissue, anything soft tissue. And right now I'm doing in-house perio. So I go to the office and then the general dentist send all the referrals to me, and then I do the surgeries there. So it's really a good workflow because the patients get to stay there, they get to stay in their office, they get to see all the familiar faces, and for me a little bit less stress because I don't have to deal with the administration, the staff, all the other stuff, the overhead, all the scary stuff. And then I'm in the practice of starting a practice, which is like a whole other scary thing. But I kind of like to mix it up. I think I'll always do a similar model to what I'm doing now, where I'm doing my own like perio private practice, plus a little bit of in-house and then a little bit of academia. So my weeks kind of split up like that.
Yeah, for sure.
Nice.
Yeah, I love that too. I mean, that's how I've got it set up as well. A little bit of teaching, a little bit of private work, even a little bit of, we have like a decent public sector here. So a little bit of public work as well, just to kind of mix everything up. It's very sort of millennial to have sort of multiple income streams and not be like all in one place, which is a cool thing, right? It's nice flexibility to have. I love it. And that's good.
My banker makes fun of me. He's like, I can't get you to sit still. Can you like hold the attention long enough? But kind of similar thing. For a while, I was traveling back to my dad's office and seeing his patients, going between his offices. And then I do a little bit of like public health or public service in New Mexico. There's a homeless kids shelter. And so we started a whole program with the hygiene school there. So I teach the hygiene school, the perio class, kind of the basics 101. And then we screen and see a bunch of kids that are in a homeless shelter. So that's like my passion project, but I think it's good. You need a little bit of everything to keep you, keep you busy.
Yeah, no, it's awesome. That's awesome to give back and have that initiative to do that. So how I wanted to sort of stage this is sort of just to do like a walkthrough, like a patient coming in, a review of sort of what you do for your assessing of perio, and then we'll go on to talk about the diagnosis and treatment from there based on how the assessment goes and what the diagnosis is for the patient. It's funny because, I graduated in 2016, so it's been, maybe like about 5 years now. And it seems like things have changed because I was demonstrating for the final year dental students at the dental school here in Melbourne. And they're talking to me about like grading and staging of perio. And I was like, what? Like none of this stuff all this stuff is very new to me. So I thought this is like a great opportunity to get to ask you and sort of get caught up to speed. And hopefully other people in my boat who haven't maybe kept up with literature and things like that since graduating can, get up to date with this stuff as well. So let's talk about assessment of perio. Sort of talk me through sort of what you do, what your workflow is, what tools and things you use, and then we'll go from there.
Okay, so kind of my private practice workflow, I guess, which is not very different, but a little different than the academia setting. But in private practice, always starting with the radiographs. I usually have an FMX because even, let's say in the general dentist office, we always have an FMX, a Pano, there's a CBCT available. So if we need that, I have that. If it's in a perio office and it's sent for, say, the lower right quadrant, then the general dentist usually sends that x-ray, but I tend to request the entire set because I want to know, what's going on. And I'm not, I don't like saying it because then I had my staff repeat it back to the general dentist one time, but I'm not a one-tooth kind of doctor. Even if you send it for this, I'm going to look at everything and give you my whole assessment for the patient. So start with the x-rays. I'm looking at the bone level. If we have past x-rays, that's always helpful. Before I even see the patient, so I kind of glance at the day and look at the x-rays ahead of time, look at the consults ahead of time. And then when I sit with the patient, I start with the health history and I tell them, like, we're going to sit down, I'll review your health history, review all your medications, ask you some questions about your family, we'll go through it together, and then I'll see how I can help. And then they say, okay. And then that's where we start. So going through, because a lot of times, even with the health history, they'll say, oh no, I'm not taking any medications. And that they mark something and you're like, wait a minute,
I love that.
Every time, every day. And the girls are sitting behind with the clipboard and they're going through it too and kind of making notes on the side too. Because, and then I think it's good for the patient too, because it takes a little bit of the guilt and the responsibility away from them, because it's an intimate place to look in your mouth. I don't want them to feel like they're being judged. I want them to feel like I'm there to help them. Mm-hmm. And if I explain some of the medications you're taking can affect your gums, your periodontium, if you have a family history. So then I start to ask, did mom or dad have dentures? Oh yeah, doc, they had bad teeth. So I like to get to know them. And that's the first step for me. And it's part of the first step.
Yeah. And so in terms of so you've gone through the history, and which is actually, I think, overlooked. Maybe I think a lot of general dentists maybe just kind of brush over that quickly and, oh, do you smoke? Do you have diabetes? Nope. Okay, good. And then they'll kind of get on with it. What are some sort of medication classes that you think are sort of really relevant that we should be looking out for?
Okay, so the big things that I want to know, and a lot of my perio patients and just the population in my area, if they've had chemotherapy or radiation, I want to know. If they have a lot of medications that they're taking, I want to know, because then that's going to lead to dry mouth, caries, issues with their gingiva too. If they have diabetes, I want to know their last A1C, because I want to know if they're controlled, they're not controlled, are they taking any type of medication? What else? Different seizure medications. Basically, I want to know everything. Supplements, if they're taking any supplements, because some of those will have an impact on bleeding. Everything.
Okay.
So I want to know everything.
Pretty thorough from that. Okay. Let's do the clinical assessment then. So you've gone through the medical history and all that. So I know in private, and I'm sure it's the same in the US with a lot of the corporate chains and stuff. Obviously, time pressure is a thing. So a lot of general dentists might resort to sort of the more abbreviated, you probe the 6s and the centrals type thing, or a PSR, or a CPITN type thing. What do you think of those more abbreviated versions versus like a full mouth probing? Or just give me your thoughts on sort of the assessment of perio with the probe.
So the interesting thing is, I think it's taught, obviously we teach it in the States, but I've never seen anybody implement it here in the States. I think it's more of a overseas thing.
Okay.
Obviously looking at the molars, the incisors, and that's supposed to give like a general idea of the patient's mouth, but I've never seen anybody do it in private practice.
Okay.
So it's taught, but I haven't seen anybody do it. They're either probing full mouth or they're not probing at all.
Yeah.
And I've even had like a prosthodontist that's a really good referral say, I don't probe, I'll just send it to you. I don't even think we have a probe in the office. So,
Yeah. That's interesting, because we were talking about this a little bit in the pre-chat, the differences between sort of like maybe Australia and other parts of the world versus North America, where there's like such a heavy hygiene model, or maybe the hygienist will do most of the probing and things, and the dentist might just come in and assess it and make their comments and thoughts on it. But here, because the dentist is doing it themselves, like they'll oftentimes be allocated like 30 minutes for like a checkup and a clean, and a dentist does that. So I think that's why we've sort of resorted to these like screening tools. So you do like the abbreviated version. If there's no red flags of like a 6-0 pocket or something, then you kind of accept that will be sort of overall a good sort of indicator that you can kind of move on with a regular clean versus something a bit more thorough or deeper. Okay, so in terms of the probing, then how often or how do you do it? What's your protocol of like how often you do it? How do you track that?
Okay, so I kind of do the hygienist usually probes ahead of time, or the general dentist. And if they are kind enough to send me the chart, then at least I have a guide. Let's say I have a chart and I'm rechecking, I still probe full mouth. But I think with time, because I'm so focused on perio versus general dentistry, is very hard. I've always said it. You have to know everything about everything. You have to be an expert in perio, endo, ortho, peds. You have to know when to refer, what to do. It's very overwhelming versus perios. I'm focused on this one thing. So I do full mouth probing on every new patient, and then annual checkup patients as well. The biggest thing that I learned in residency that made me feel so much better, our pre-doc perio faculty was so strict, so stern about every little number. We had this one instructor, and he would come and kind of not yell at us, but a little bit. It's like, why'd you put a 4? Put a 5. This is a 5. And I'm like, oh my God, it's one number. Does this matter? And then once I got into residency, we spent like 3 or 4 months on all these things, and the pressure is different between examiners, the probing force, the probes are different. Yeah. It's different in that same patient from day to day. And I thought, why was it's not like we're calibrating the faculty. I know we're not calibrated on faculty now. So it does make a difference who's probing. So I know how I probe, and I know I probe very lightly. Yeah. So I do it for myself. For patients, I don't tell them the numbers, because how are they supposed to know what 1 millimeter versus? Yeah. Some patients are very dentally savvy and have a high dental IQ, especially in my area. I see a lot of physicians, a lot of pharma reps, a lot of like laboratory workers just in the area that I'm at. So I'll let them know that I'm checking for inflammation. That's just the word that I use. I'm looking for inflammation. And then I try not to probe too heavy, because they say, oh, that pokey thing. And so I don't want them to associate me with pain. I want them to have a good experience. So I know what I'm looking for, but I'm also very, very gentle.
Okay. So
do probing, looking at recession, looking at the gums. I'm looking at mucogingival defects. A lot of clenchers, especially now after COVID, the pandemic. So looking for those abfraction marks. I'm looking for tori, asking them if they have a night guard. I ask them if they sleep with the CPAP. I do a brief head and neck exam. I do the whole shebang, but very quickly. I know it sounds like it's a long process, but I've gotten in that flow of like, I do this, I do that, I do that. And
got your routine,
I got my routine.
What about the role of CBCT? I know you mentioned that you have it available to you. Sort of how often would you order one, or, if you're not planning for implants and things, in terms of your diagnostic process, how often would you rely on a CBCT for that?
Every single implant patient will get a CBCT. I was listening to one of the other podcasts that you did with the oral surgeon, and you guys were talking about like GBR, and if you do it before a big bone graft procedure, sometimes I will, because if I want to know where the nerve is, if I want to estimate even the amount of bone that I'm going to use. So sometimes I do take it pre-op for ortho cases too, so I can exactly measure where that tooth is that I need to go in and put the bracket on. Sometimes even for ortho extractions, if the tooth is, way up into the sinus, I want to know sinus procedures. So we do it pretty often.
Yeah. Okay. So you've done your assessment, you've done the health screening, you've done all that. You've done your probing, you've looked at the radiographs. Tell me a little bit about sort of your diagnosis process, and then also sort of how that plays into your management of how you decide the patient, or how you consent the patient or inform the patient of what needs to be done.
Okay, so let's say, for example, with like an osseous or a traditional perio patient, my general rule for my referrals, my hygienist, everybody, if let's say the patient's systemically healthy, they're in pretty good shape, there's not any contraindications. If the probings are deeper than 6 millimeters, I don't even recommend doing non-surgical or a SRP, unless there's heavy tartar, they haven't been to the dentist in a long time, and there's a benefit to doing SRP. I usually don't think there's a benefit, just from a research standpoint too. We can't get the hygiene instruments beyond 6 millimeters. So, I mean, I don't know about in Australia, but in the States, SRPs are expensive. So the patient's going to waste all this money on an SRP, and then you're going to do the probings. It's not going to improve. And then they go into a surgical phase for what, when I could have done, from the start. And so that's kind of my hard rule. If it's beyond 6 millimeters, then it's coming to me. Start to prepare the patient that it's, I call it a surgical deep cleaning, because the patient's not going to know what osseous means. So if I say a surgical deep cleaning, and then I explain that I have to open a flap to physically see what's going on down there. And then, so that's for traditional perio. And then it helps to show them the x-rays too. I'll show them like, these are your teeth that you see. This is the bone that holds the tooth. This is where normal bone level is. And this is all the bone loss you have. So I need to do this and then try to preserve what we have. And then I explained relapse too, because I know a big question, at least from my friends that are general dentists here, how effective is SRP? How successful is osteosurgery? Should I even do osteosurgery? Because those perio patients tend to relapse and relapse. So just letting them know, you have to update us with your medication, update us with any life stress changes, changes in job, changes in hormones, explain that everything affects their gums. And then they understand and they're motivated and they're passionate. And then that helps too with them going to recalls, kind of let them know you got to go to your 3-month cleanings. You can't do 6 months cleanings. And so,
yeah, build it up from there. So in terms of just going back to diagnosis a little bit, to talk through that, with the newer sort of staging system or grading of the diagnosis, is there like a decision tree of, okay, if it's regardless of if it's like pockets of this many millimeters and then there's a systemic factor, it'll fall into this category, so then I'll treat it differently? Or does everyone sort of at the baseline go through just like a good deep cleaning, whether it's surgical or non-surgical, and then sort of proceed from there?
Okay, so with the new classification for perio, the idea behind it was to make it so that the public can relate to the classification system. So they specifically, with the old classification or the Armitage classification, kind of the backstory, the juicy story that I got in residency was that they stuck Armitage in a room at one of the AAP meetings and they're like, you need to come up with a classification. Yeah. And he was like, I don't know, I just came up with this thing. So we kind of put a bunch of the key leaders together and they had several meetings. It took a few years to come up with the new classification. And then they took into account things, like you said, like systemic factors, because we know diabetes, heart disease, there's all these other systemic links between perio and heart disease, diabetes. Specifically, it talks about the A1C not being controlled. And then if the patient's a smoker, because that completely changes how you're going to heal, how your body responds to periotherapy. So they added that. And then they did it in staging because they wanted to relate it to like almost cancer. Because if you have stage 4 cancer, it's not good. So they thought if we do it this way, then patients are going to know this isn't good if I'm in this category. I don't know if it works or not, but that was the idea behind it.
Yeah, it's interesting. Some of the MaxFax guys I was talking to work, and they're kind of making fun of it a little bit. Like they've made it so serious, like it's a cancer staging and stuff. And it's just, but it's funny. But I do agree. I think it's much easier for a patient to be like, oh, I have like, they understand the grading system of ABC and then staging like 1, 2, 3, 4. Right. It's much easier than telling them, oh, you have, generalized severe chronic. It's like a lot of words for them to kind of comprehend. And so I think it does help on that patient education or understanding.
It's a lot of words. And the old classification too, I talk about it with my friends, like every single patient was generalized, moderate, localized, severe, generalized, moderate, localized, severe. Even if you didn't know and you're like, what is 30%? Just put generalized, moderate, localized, severe, and it was probably right, And you can never move on versus like the new classification. Let's give an example of a patient who has 2-3 millimeters everywhere, but clinical attachment loss, lots of recession. They've had perio surgery before, but they show up to their maintenances. With the old classification, they would have still had severe periodontal disease, even though clinically it doesn't make sense. So versus with the new classification, they're considered reduced periodontium, but they're healthy.
Yeah, healthy but reduced periodontium. All right, so during dental school, we did a lot of like SRPs and stuff, but we never got much exposure to like surgical perio. So tell me, I'm just interested. So how does that work? And so are you doing it like sort of one quadrant at a time? If it is like generalized, or is it, if it's just like a localized, it's like the lower right sort of, I guess for you guys, the numbering is different, but like 3, 6, 3, 7, which is like 22 or something for you guys, like, maybe 27. So like
it's the canine, lower right canine.
So I'll go back. So 24, maybe the bottom left molars. One number.
Okay, so like 19, 18.
Yeah. So if it's just those two that have defects and they're like frication involvement and things like that, what's like periosurgery to manage that? Like, can you just talk me through that procedure, what it would be?
Sure. So say they have deep pockets, some bone loss, you can see it, a little bit of furcation involvement, then the osseous surgery would be the treatment plan. And usually what you do is you open a flap and you look at different factors. You're looking at the tooth shape, the root trunk. Say someone with a shorter root trunk, you can't remove as much tissue as someone who had a really long root trunk. And that person who has a long root trunk, they can lose quite a bit of bone before it starts to get into the furcation. And then I tell patients, that's when I start to worry when I see bone loss in between the roots, because it's almost impossible to fit any instrument in there. So it's hard to clean in there. Yeah. And then depending on the bone loss, you either do bone graft or some guided tissue regeneration with some membrane to try to regenerate a little bit of bone and then preserve what they have.
Mm-hmm. Okay, so it's not just raising a flap just to visualize all the sort of subgingival calculus and clean that off and then close the flap. So that's not what you would classify. So if you're going to raise the flap, you're doing grafting and things after you've clean everything up.
Usually so. Like the kind of rule of thumb with perio is you're either doing resective surgery where you're opening the flap, cleaning everything up, and then closing the flap, or regenerative where you're trying to get some of that bone to grow back. Say if you have a horizontally flat bone loss, you're not going to be able to grow it back to the CJ. So in that case, you wouldn't do anything, but typically it doesn't, people don't horizontally lose bone like that sometimes, but usually not.
So if it was like just like a generalized perio case with like 7 mil, 8 mil pockets, you would just raise a flap just to clean everything and then close it up?
If it was like horizontal bone loss, then, no bone graft needed, then open the flap, you can clean it up. The cool thing, you probably can't do this in Australia, and here in the States, it kind of depends state by state, but in California and New Mexico, 2 of the states that I've like practiced in the most, the periodontist can open the flap and raise the flap, and then the dental hygienist can come in and do the SRP with flaps. So that's pretty cool. Like it's really cool. It's my least favorite surgery to do. So like long term, that's a goal, to get hygienist well-trained enough, that's passionate about perio to be able to do that. And I think for them, it's very rewarding and fulfilling too, because they can actually see the tooth, see the roots, rather than that tactile feel of SRP,
So then you do, and you just come back and close it up after they're done.
Right.
That's pretty sweet. I love the North American way, just like so different too. I got when I first graduated, I graduated in Australia, but then I went back to Canada for a year and I was working there. And it's just like you just get so spoiled. Like your assistants like take the like radiographs for you, like they'll like pulp test even. You just come in, like they put the rubber dam on. You just like, and then here you come back and like you have to take your own X-ray. Like it's like nothing. So it's just like so different how the model is built. Yeah.
Oh my gosh, I would die. I don't even think I could know how to use the X-ray machine, the CBCT. Forget it. Like I would die.
All right. So for the just traditional classic, so I guess it's in terms of vocabulary, SRP versus SRD. Is that any different? Or is that just sort of different wording?
Maybe for Australia. So SRP would be scaling and root planing, and then
debridement.
SRD would be debridement.
Yeah.
So from a like perio, like technical standpoint, the scaling is different from the root planing, and the thought behind it was way back in the day, like the old school perios. They used to think that cementum was also diseased, and you had to remove the entire cementum and leave the roots like glassy smooth. So that's why it was scaling and root planing. So removing all that tartar, all the noxious elements, but then also making the surfaces like glassy smooth. And then we found out later through research and, different studies that not all cementum is disease cementum, and we have no way of knowing what's disease and what's healthy cementum. So we don't do the glassy smooth. So you might see some of those patients in your practice where you can see like the like tooth loss, the roots are very smooth and almost notched from all the SRPs that they've had.
Yeah. So the proper vocabulary then is SRD. Is that right?
There, debridement?
Yeah.
I've never heard that. This is my first time.
Okay, so SRP, it just means like just get deep clean, pretty much.
Yeah.
So a patient that needs a full mouth SRP, would you like, whether yourself or your hygiene does it, is that done sort of over 2 appointments and you just do like sort of quadrant 1 and 4 and then 2 and 3, or do you do full mouth at the same time? And then we'll talk about antibiotics and stuff after that as well, or adjunct treatments and medications.
So it kind of depends. I've noticed like the dental hygienists don't like to do the full mouth in one appointment. They like to do the right side first and then the left side first, just because of time constraints and like what they can, tolerate. And it's hard for hygiene because they're using their hands as repetitive motions all the time versus, at least for us, it's, different hand motions and a little bit different ergonomics. So usually if it's a hygienist, they like to split it up in visits. I will sometimes still do SRPs myself. And then if the patient really wants everything done in one visit, they want to get it over with, then I'll tend to do it myself and I'll do the entire thing, but I tend to do it under IV sedation because it is a longer procedure. So if I can do the sedation, let them get comfortable, I'm comfortable, we can take our time a little bit more. And then in those cases, I do recommend giving antibiotics because some of the studies show that it can raise your temperature a little bit and you can get a little bit of that bacteremia from swallowing all that bacteria. That we can only get so much with our saliva injector and stuff.
So. What's the sort of antibiotic that you recommend normally for that?
Just amoxicillin if the patient's not allergic, I want specifically.
Okay, nice. All right, so we've talked about the diagnosis, we talked about assessment, treatment. I guess let's talk a little bit more, just like, more advanced procedures of different grafting options. So I guess something that a general dentist would often see is, these, patients in their maybe 40s, 50s, 60s, they come in with kind of like recession. So they're, the root surface is visible and they're often asking sort of what are the options. So obviously, we can do it both ways. So just in terms of what can be done as options so that dentists can tell their patients, even if they're not the ones carrying out the treatment, so they know they can have the option to refer this out if they need to as a starting point. And then also sort of what the actual treatment entails and how it kind of works. That'd be good to go through.
Cool. Okay, so let's say a patient comes in, they have gum recession, they start to notice kind of what I do and what I recommend that general dentists will do once the patient's there. I'll take photos. I always have my camera with me, or at least the intraoral camera from the office. Take a photo and then show the patient, this is your tooth, this is the enamel, and this is actually the root that's showing through. And there should be bone covering the root, and then your gum should be covering the root. And then I explain kind of to patients that we have two types of gum tissues in our mouth. We have tissue that has a lot of keratin, like the palm of our hands, and that's what withstands all the pressure from brushing, eating, chewing, talking, flossing. And then we have a more delicate tissue like the top of our hands. And then I show them the mucosa, like the inside of your lip. And that one's weaker. Think about grabbing something with the top of your hand, it would be painful. So I explain that we need volume and lots of collagen, and then we need lots of keratin. And then those words are what patients seem to understand. So I think if doctors and general dentists explain it to them like that, then it would make sense.
Yeah. Okay. So I have that chat with them and they're interested, like, okay, doc, what are the options? What can I do? Well, how would you like reply to that?
I tell them to stay off the internet. No, I definitely do recommend for them to stay off the internet, because then a lot of them will start to Google and then they open up these chats and people will say, oh, I've had gum grafting, it hurts so bad. And so I don't want them to have that, that misconception that it has to be painful. Yeah. And so it's depending on the tooth that's affected, because different teeth in the mouth respond different ways. So all the maxillary teeth are generally a little bit easier to get coverage. Let's say if it's just buccal recession and the interproximal tissue and papillas are still intact, like minimal gum recession, versus somebody who has generalized horizontal bone loss, then in that case, we can't make them go back to baseline. So the sooner we can get the patient in to get the procedure, the better the results. So for the maxilla, just depending on how many teeth, if it's localized one tooth, then autogenous is a good option. If it's the entire maxilla, and say for us, the numbers will be 3 through 14, then sometimes I'll recommend like a dermis or a collagen matrix option if they want that, because then they have to get the entire palate grafted if they want to do everything in one visit. And then for me, at least in my hands, it's I get better results if I do everything in one visit versus like one side and then the other side. Because you can pull the flap, at least I can, if I'm doing everything versus just one spot and then another spot. But some people still want autogenous. Obviously, that's a gold standard. Your own tissues, the best tissue, you can get the best results with that. You can still get what we call creeping attachment. So say I can't cover the entire root all the way. Even if I get a little bit close, then with time, if you're brushing correctly, you're brushing properly, sometimes the tissue will bounce back a little bit. So, and then I tell patients that in the mandible, I usually split it up into sextants, at least like the anterior teeth and then the posteriors. I'm not there yet with my skill level, at least, to do the entire mandible in one visit. And then in the mandible, I usually always recommend doing autogenous tissue. So just kind of explaining to them that there's different options. You're going to get online. You can find that there's collagen, there's human cadaver tissue, dermis, like an alloderm. And then your own tissue, which is the best tissue. And then, of course, there's different techniques to do soft tissue grafting. So thankfully, I was lucky enough when I was in residency that I got trained in. I went to Dallas. I took the Pat Allen alloderm class. I did like the pinhole training. So Loma Linda was very good about teaching us tunneling. They taught us flaps, like everything you can think of. We learned it. So I just let them know, like, this is what I can do. This is what works in my hand. This is my recommendation. And then leave it up to them to decide what type of tissue they want to use.
Yeah. Why is it that, is it just related to like blood supply that the maxilla is better than the mandible, or what, or is it more like the occlusal forces on it, and what causes the maxilla to be more predictable than the mandible?
I think probably a little bit of occlusal forces. I think if you think about it, the mandible has a little bit of flex to it. And then on the mandible, we tend to have more muscle pull. So kind of gravity, I guess, working against you a little bit. The tongue's down there, you know, that gets curious. So it's definitely tough. It's a tough area.
And what are the, I guess, the success rates or like predictability of these grafting techniques?
Okay, so that's depending on the interproximal bone level. So there's different classifications, either like a Cairo classification or a Miller classification, but the commonality is that they're all looking at the interproximal bone loss. The more interproximal bone loss they have, the less predictable the coverage is going to be. So someone who you already have those black triangles, it's going to be almost impossible to make it go back to normal, you know?
Yeah. Okay. So I guess that's important to know from our perspective too, even for the ones referring out, to be able to identify at least at a baseline level, okay, this is sort of something that can be done predictably or not. Obviously they'll come to you or the perio and they'll be able to tell them more accurately, but I think that's a good sort of thing to have in the back of your mind as well.
The sooner the better. It's one of those things. And patients will ask you, how long can I wait? You know?
Yeah.
So, and then sometimes I tell the patients you want to look at overall their phenotype and the translucency and the color of the tissues too. Sometimes there's young females and they have very thin translucent tissue, very like square shaped teeth, very beautiful long teeth, but you can see all the root prominences. They've had ortho. So I kind of let them know, like, you know, like I had a patient not too long ago and it was just a little bit of gum recession, but I could see all the roots. They said, eventually we're going to have to do some type of phenotype conversion where we augment and thicken the tissue. So even though they don't have that recession, they're still, you know, at greater risk for getting the recession, losing their teeth. Yeah, exactly.
Yeah. Be more proactive about it. One, I guess, situation that, I guess it kind of depends where you work and stuff like that too. Like I'll see a lot of patients sort of in some of the areas that I work are a little bit more sort of maybe lower socioeconomic, is they'll come in, they haven't been to the dentist in, 10, 15 years and they're like in their mid 40s now. And just real severe perio, right? Like all the teeth are like frication involvement. There's like the lower anterior is all like mobile. But they're like, oh, I'm not in pain. Like, why would I, and I'm eating and functioning okay. Why would I like consider a clearance, for example, or like taking teeth out and replacing it and things? How does that discussion go, or what's the rationale for people to just leave it until it has to come out, or is like infections and things or pain and symptoms dictate it? Or how do you have that discussion of, okay, this might be a difficult choice to make, but it might be time to consider extraction of these terminal teeth and replacement options and things?
I'm exhausted thinking about the conversation.
Yeah.
So I've practiced in different places. Where I practice now is very different than when I was
Yeah.
before, but I have had patients like that. It's very frustrating and it's almost saddening because it doesn't hurt. It's a chronic disease, so it's not
Yeah.
going to hurt unless it's an acute infection,
Mhm.
something got stuck in there, or it's a perioendo lesion. And some patients, honestly, they don't care. They're going to wait
Yeah.
until it's hurting and it needs to come out, and it's like a tooth by tooth situation.
Mhm.
And then some patients are surprised, they get emotional because they haven't been in pain, so they didn't go to the dentist. Maybe they were putting their kids first, their braces first. And so it's really, really hard because then you're diving into the patient's psychology and what
Yeah.
happened, but trying to explain to them the rationale behind why it's not going to hurt because it's this slow progressing disease. And then it kind of goes back to that cancer comparison. Usually you're not going to know that you had cancer. It was found because of something else. And then by the time you find it, it's too late, right?
Mhm.
So I hate to compare it to that, but I think it
Yeah.
goes back to that diagnosis classification change.
Yeah, that's a hard. I've like it is very sort of area dependent because like it just some people just access and finances and things because
Yeah.
they'll come in and be like, oh, this one tooth is sore, and then you're like, we got to take everything, or like and then they're like surprised by that too. It's a bit of a hard discussion to have for sure.
Yeah, that happened to me. Like one of the first cases out of residency, and they went in for one tooth, and I took a PA, but we ended up taking a full FMX. And you can see the abscess on that canine tooth, which is a crucial, essential tooth.
Mhm.
And just everything was generalized, chronic, severe perio. And I'm like, this is like an all on four case or a denture case, but
Yeah.
I can't see anything. And the patient was upset because they came in for this one area, but I'm looking at everything. And I explained, I took my time. I said, this is a chronic disease. This is what's going to happen. This relates to your diabetes, all these other systemic issues. And then they're like, okay, I understand. But I'm going on vacation, so maybe next year I'll come back and get this done. I'm like, okay. And then for me too, I worry about the liability because if you're diagnosing this and a patient's walking around with this chronic infection, if something happens, Ludwig's angina, you just never know. It definitely makes me weary.
Yeah, it's tough. I guess, I mean, our job is just to inform them, right? Ultimately, it's their choice on how they proceed with it. But it is a tough situation, I think, to have to face at any stage of the career. Okay, so I mean, that's been pretty useful. We've gone through sort of a lot there in terms of what you do to assess sort of the diagnosis process, treatment. Just one more thing on treatment before we kind of just transition is, so in terms of your recall maintenance, so the patients come in and they've got sort of 4 to 5 mil pockets. So you do your yourself or your hygiene does the clean. Is it sort of a 3-month thing until they stabilize and then you prolong it? Or what's your sort of like normal protocol for that?
Definitely a case by case basis, but I tend to recommend 3 to 4 month maintenances for most patients. I think it's rare that you should do maintenances every 6 months. Mm-hmm. I think it's a huge misconception because of insurances only covering it every 6 months. So that's why just the general public thinks that they should get cleanings every 6 months. Mm-hmm. But again, with the area that I'm in now, most patients are pretty accepting of the treatment and the tightening of the maintenance schedule. Mm-hmm. The way that I explain it is that once you've had periodontal disease or a perio infection, you're more likely to get a relapse if we change medications, your stress, changes in jobs, you move, your ability to cope with stress changes, any little thing like that, you're just more sensitive because your body's ready to fight. So I kind of liken it to an autoimmune disease. Yeah. I say it's not quite like an autoimmune disease, but it's your body trying to fight off that plaque. So as soon as it senses something, it's going to be ready to fight that infection again. So I need to see you every 3 months, or they alternate with the dentist. It just depends on where I'm at, where I send them to for, the maintenances. but most patients, I think, need to be on a tighter schedule. Some of the perio studies, they were seeing patients like every 2 weeks to maintain them. So even some patients that like say yoga instructors or they're heavy workouts and they lift a lot and they build up calculus really quickly, even those patients, I'll recommend that they come in.
Is that a link? I didn't know that.
Well, in my mind, if you're like having a lot of protein, those patients tend to build up calculus on those lower central. Yeah.
Okay. Interesting.
In my mind.
It's anecdotal, but it works. Yeah. That's like my famous anecdotal one that I have is like patients who have like lingual tori and stuff. It's like notoriously hard to take teeth out on them for some reason. Like there's like the bone density, or I don't know if it's like they're all like, or if it's like a function of bruxism that they've developed the tori or what it is. But that's like my one that I'm always in my head. I'm like, if I see it, I'm like, oh, it's gonna be hard exo, like no matter what.
In my mind, it makes sense. It's a funny story between the tori thing. So it's one of like the famous perio guys. There's like a few older periodontists that are all Swedish, and they started like dental implants. So one of them was my chair when I was a resident, and he brought over a friend to lecture, Steven Renberg, who's like super, super famous in our world. Mm-hmm. And he says, no, we know that tori was caused from bruxism, but we had no way of doing the study. Mm-hmm. So in my mind, I'm like, oh no, you're bruxing or you're clenching, but there's no study that shows it. Okay. So it's just
so there is some sort of acceptance with that. All right, so
the juicy perio gossip.
The latest and greatest. All right. Yeah. One other like kind of nerdy question I have is just in my own like regular life, I'm like really big on sort of like health and longevity and all that kind of stuff. Is there much in the pipeline in terms of maybe early picking up of like chronic disease, like with biomarkers or like in the saliva or the types of bacteria in the periodontium or something that is being worked on or is available that people are like can use in terms of diagnosing maybe diabetes early on or like other health, like heart problems and stuff early on? Is there anything like that sort of developing or any thing like that available?
Yeah, so there's definitely companies that are starting. I actually have a good friend. He's a general dentist here. His name's Dr. Rob. His office is like a big referral for us, and they do the biologic testing, the saliva markers to check the different bacteria. So I think we're getting there. I don't know if we're quite there yet, but I think that's the new wave that's coming in, because we definitely know it's the red complex, right? We know it's certain bacteria, and then the good versus bad, and when it topples over to more bad bacteria. But then the component that I think we're lacking is our own autoimmune or our immune response and how we're responding to that bacteria. So there's different models in perio, like the random burst theory. So say I had perio, we're kind of under control, and then 20, 30 years later, we get it again, something happens, we get it again. Most people are on that continuous slope where you just kind of slowly go and go and go, and it's just growing. And then the more rapid type on someone who's younger and they just get it out of nowhere. There's not really a correlation to all the tartar and the calculus. They just have full blown bone loss all the way to the apex. So figuring out that genetic link and what's going on in our individual response, I think that's the next step in perio. But yeah, there's definitely they're starting to, but I don't think we're there yet.
It's in the pipelines. No, it's really cool. I think that's one of the, I've always sort of liked perio a lot because of that sort of systemic factor and componentry to it, which is pretty cool. Like if like, your periodontal health can affect your diabetes and vice versa, and heart disease and stuff like that. I always find that really interesting.
And they'll give my friend, Dr. Rob, they'll give the patient like a report card of all the bacteria that they tested. And so the patient brings it to me. So then I already have the heads up on like what's going on,
Yeah. No,
it's very interesting. Like you said, some people respond well, some people don't. Some people just don't respond to perio treatment at all. But I think that's why that workup, the initial consult, asking about their family history, that tends to build the overall like big picture. The girls laugh at me too at work, our assistants, because they're like, you're so fast. It really doesn't take me a long time to do the exam, but it's like, they say that I scan the patient up and down because the patient like, did you have skin cancer? I see a scar here. And I had another patient that they were referred for something else, but I'm pretty sure they have an autoimmune disease going on. We'll see what the biopsy says, but
Yeah.
I don't know. Perio is just so interesting. All the systemic links.
Yeah.
I love it, obviously, but yeah.
And the last thing I'll ask is, it's always interesting and fun to speak to like young specialists because they're just starting out. And one is, they're just, in terms of the academic side of things, that's really recent in your head because you've just gone through all the literature and stuff in your training. And what are your, I guess, thoughts or insight into sort of like the future of perio, say in the next like 20 years? Like what's going to change? What's going to advance? What are we going to do differently that we're going to look back on like, I can't believe we did that? Where do you see some of that kind of stuff?
I would have never even thought about this. I don't know. I know some people feel like, oh, perio is a dying specialty, but people used to say that about endo. And so I've never felt that. I think perio always adapts. Like, it was periodontists that started doing dental implants. We started the classification. We used to think to put implants where there's good bone. Now we're learning about soft tissue around implants, which has been really neat. Different types of implant coatings have changed the way I practice. Digital dentistry, I love digital dentistry. So that might be like the future. Yeah. At the school, like some of the residents have the XNav. So to see them putting in the implant in real life time on the 3D scan has been wow. Really, really cool. So I think once we fine tune digital dentistry, that might be the future, like guided digital. If you can, it's one thing to have the scan, but if you can look at the scan while you're placing an implant, like that's really cool.
What's that? So is that called XNav? Is that what it's called?
XNav.
Mm-hmm. Yeah. Nice. I know that. So you get live sort of feedback.
Yeah, while you're placing the implant. I'll send you pictures of them.
Yeah, it'd be cool. I'll add it in the show notes for people who are sort of interested.
Yeah.
Awesome. So thanks
Yeah.
That was really good. That was like a really good sort of catch up on perio to see what's available, what's possible in terms of treatment, diagnosis, sort of things going forward. Anything else that I didn't ask you that you think would be useful for someone who's interested in perio to know in terms of any stages really that we talked about?
Do it. I just do it. Like I hate when I see people that are like, oh, I want to do it, but I have this, and like all the buts. If you feel like you want to do it, then just do it, apply and go for it. I think because I'm such a perio nerd, people just assume I was like top of my class, super smart, super go-getter. And like, I was just trying to survive. I was like anybody else. Dental school was hard. Like I said, you have to know everything about everything. And to be an expert on everything in dentistry, it's so hard. You get so in your head. But I really liked this one thing. So I think if you're passionate about something and you feel that calling to do something, then just take the leap and go for it. Like, what's the worst that's gonna happen? They tell you no, okay, fine, try again.
Yeah. No, that's awesome.
Yeah, I feel that. I know. I'd like to see more girls in perio, more females, more women in like the perio. It's been interesting having like social media. Patients will come to me from social media, and I had one patient and she said, I want to know who my doctor is. I want to know you. I don't want to go into some old guy's office and like, hey, I'm here to do your dental work. And so I thought that was so interesting, but I'd love to see more females in dentistry too.
Yeah.
In perio.
Yeah, I think that's sort of a natural progression that's gonna like with the cohort of dental students. Anyways, I think it's I think in my year and most years that I see, it's if not 50-50, it's more females than men actually. So I think that's kind of shifting, and I'm sure that'll trickle down into all the specialties as well.
I hope so. I have 10 residents and they're all boys.
Yeah, I think we got. I mean, we are in endo. We got a lot of females at sort of Melbourne Dental School, ortho as well. Perio, I think it is more men than. I don't know why that is, but it seems to be the other specialties are drawing more females at the moment. Oral surgery, interestingly, is getting more and more females coming through as well, which is pretty cool because that's been like pretty traditionally sort of male dominant sort of specialty. So
my protege, I lost her to oral surgery, but I mean, I'm happy to have more females in the field, period. But I lost her to OS.
No, I think, I mean, there's a lot of parallels between I mean, I think perio is quite surgical in itself, right? So that's why I'm really interested in perio as well, in terms of if I was going to specialize. I think that's probably what I would do in terms of the work, because I think it's like a cleaner surgery in a way. Like MaxFax is, especially just like oral surgery, it's pretty like macro, just big flap, take it out as quick as possible, atraumatically as possible. But perio is more sort of like finesse a little bit. So I like that side of this. It's like more finesse surgery. Just
it's planned. I liked, at least at Loma Linda, it was a lot easier to shadow in the oral surgery department. And I went to school with a few of them, so I could just pop in. They were very laid back, so I could pop in very easy. But with perio, it was like you said, very clean, very planned, very organized. Pre-dental students will ask, like, did you think about oral surgery? The only reason and like my rationale as to why no and never, and you know, I love those guys and ladies and I love what they do, but the trauma, I could not deal with like the gunshot wounds, the big flaps, like the blood. I don't even like blood on my instruments. Like I want them wiped immediately. So it's, you know, like my hat's off to them, but the trauma side, that's like the big difference.
Yeah. And I guess that's a big component of the training process. Maybe once you're finished training and you're in private, like you don't get much of that. But definitely you got to go through it during the training process. So that makes sense. Awesome. Thanks for coming on. It was great to chat with you and to have the opportunity to sort of ask you questions and about perio. I'll put a link to your Instagram page for anyone interested that can reach out to you. Hopefully you can help them out. Apart from that, if you can send me the information on XNAV, that'd be pretty cool to check it out.
Thank you for tuning in for another episode of the Newbie Dentist Podcast. Please be sure to subscribe and head over to iTunes and give the show a 5-star rating. For all show notes and to access all previous episodes, head over to www.newbiedentist.com. Have a great day.